Mucha suerte.
Ok, gracias.
Cuando quieras, Dani.
Okay. Good morning, good evening, good afternoon. We know that we have an audience from all over the world. I am very pleased to have this webinar with a group of doctors that I admire as surgeons and as human beings. So I am very happy to have the chance to share with all of you this webinar. Thank you, Juan Carlos. Juan Carlos González is a shoulder surgeon from Colombia, and we know each other for 30 years, and he will share with me the responsibility to moderate this session. Juan Carlos?
Danny, how are you? Thank you for the invitation. I'm very pleased to be here. And of course, our role will be more in a second line. We have wonderful doctors, wonderful guest speakers. And if you deem convenient, we can just begin.
Of course, let's go ahead.
Okay, so our first speaker is it's a pleasure to me. It's a privilege to me to present to you John Sperling. John is an orthopedic surgeon from the Mayo Clinic. He did his medical training at Virginia University, and then he did shoulder and elbow at the Hospital for Special Surgery, and he has been in the Mayo Clinic since 2000, I think. He's a wonderful person. We just talked with him that we have had that relationship with the Mayo Clinic for years, and we are thankful for that. John, you are going to talk about glenoid bone preservation in reverse shoulder arthroplasty. Thank you very much for your talk and welcome.
Juan Carlos, thanks so much for your kind invitation. And Daniel, thank you so much for putting this together. Very much appreciate that. We have a great faculty and look forward to the discussion. I'll be talking about glenoid bone preservation in primary and revision shoulder arthroplasty, my disclosure. And I think what we've learned about reverse, it's that avoiding superior tilt is critical. If you place the glenoid component in too much superior tilt or in superior tilt, it's associated with an increased stress on the implant bone interface, decreased range of motion, and impingement between the humeral tray and the scapula that results in polyethylene wear, scapular notching, as well as glenoid loosening. So the position is critical. Neutral inclination and inferior placement is essential. So here's an example of one. This was a case where the base plate was placed too central and with superior tilt with the bone graft, and you can see early failure in this case. And I think one thing that we've learned is that we need to consider the position that we place the glenoid component differently, comparing an anatomic compared to reverse. When we do an anatomic total shoulder, the glenoid component occupies the entire glenoid. When we do a reverse, we place the base plate on the lower part of the glenoid to prevent impingement. So we need to consider the position and inclination separately. And this was an important paper published by Pascal Boileau in 2019. And what he noted is that when you place the glenoid component for an anatomic in the central part of the glenoid, it typically has 10 degrees of superior inclination from the central part of the glenoid. However, where we place the base plate in reverse on the bottom part of the glenoid, there's actually 20 degrees of superior inclination. And this is the term RSA angle, the reverse shoulder arthroplasty angle. And we have to correct this 20 degrees of superior inclination. So what we learned from Pascal's paper is that even in the absence of any glenoid wear, we have to correct the RSA angle. 20 degrees is required to ensure at least a neutral base plate position. And there are basically only 3 options available to correct the RSA angle. You can do what we used to do in the past and eccentrically ream away the central and inferior glenoid. You can place a bone graft, or you can use an augmented base plate. And eccentric reaming has problems associated with it. We ream away a large volume of native bone, and unfortunately, we remove the best quality bone, that hard cortical bone, and we medialize the base plate. And this has a negative impact on the soft tissue tension. We get shorter screw fixation and increased risk of impingement. And you can see in the bottom right, this is what we typically did in the past. We removed a lot of bone when we eccentrically reamed. And again, we removed the best quality bone. So 1 millimeter of incremental reaming results in a 43% decrease in contact of the base plate with cortical bone. How about bone grafting? Well, there are challenges of using bone graft. It can be complex. You can crush the bone during the procedure. You can get fragmentation as well as non-union. And it can be technically challenging. If the graft is too prominent, the base plate will not sit on the native bone. And if the graft is too thin, there'll be no contact with the base plate. And I think what we've seen in the past 3 years is higher rates of bone graft failure. So a paper from the Rothman Institute with very experienced surgeons, Jerry Williams, Matt Ramsey, 25% failure of bone grafting in primary reverse. From our institution at the Mayo Clinic with my partners, Dr. Sanchez Sotelo, Dr. Mori, 20% failure of bone graft on revision reverse, and Brad Edwards in his paper on bio-RSA, 33% rate of graft resorption. So I think what we're seeing now, papers coming out, is saying that graft resorption in reverse arthroplasty across institutions is much higher than recognized. And I think our hip or knee colleagues will tell us, we told you so. This is something we've realized for many years. So other options available, you can use an augmented base plate. And Tom DeQuinn, one of my former fellows, did a nice study comparing augmented base plate compared to eccentric reaming and trying to understand how much glenoid bone really is preserved and how much lateralization is achieved. So Tom took 50 consecutive arthroplasties and planned them with 3D software and tried to get 100% backside contact. And what he looked for was 10 degrees of inferior tilt and how much bone is preserved using an augmented base plate compared to eccentric reaming. And it underwent statistical analysis. And I think the bottom line, what he found is that you can preserve over 50% glenoid bone as well as almost 5 millimeters lateralization. And I think with the evolution of 3D planning software, we can see this clearly. And this is just sort of an example. When you plan a regular reverse case and you want to ream away that bone, you can see how medial you are. But when you use an augmented base plate, how much bone you preserve with lateralization. So I think this is becoming a key now to glenoid bone preservation on primary and reverse. One of the other things Tom looked at is really interesting. If you use an augment, what happens is if you just have 5 degrees of malrotation, you can lose 54% contact. So Tom highlighted that preparing it and placing it in the same rotation is absolutely critical to avoid a gap on either side. So this is an example of a fracture case. I think all of us have been in these cases, particularly in an older patient. If you just start reaming the glenoid bone in a patient without arthritis, you can quickly ream away a lot of glenoid bone. So this is a case of Tom's using an augment in a fracture case to try to preserve that hard chondral bone. So the benefits, again, are lateralization, less impingement, and metal can be a simple way to be able to do that. So this is an example of a smaller patient that I took care of. And it's interesting how things evolve over time. So this is my bread and butter reverse case. I use an augment superiorly to create the tilt. And then to avoid over-lateralization, I use offset trays now. This allows me to slightly medialize the humerus. And it's interesting, surgeons have come about this in different ways. I heard Pascal give a talk, and he basically has a similar philosophy. He uses bone graft on the glenoid, I use an augment, but we both use offset trays to adjust the soft tissue tension to be able to achieve the same goal. And here's another example of using offset trays in an augment to be able to manage glenoid wear. Here's a patient sent to me. I think one thing we've seen now is the burden of revision arthroplasty is increasing dramatically. So this was a patient, unfortunately, that had a failed stemless. The surgeon amputated part of the lesser tuberosity with the freehand cut and then anteverted the glenoid. So this is a combination that's a setup for failure. So we went ahead, revised this. You can see we removed the glenoid component. We used an augment to create the tilt in this case. Here's another example of one. This is an example of more significant glenoid bone loss. And what we did in this case, you can see the whole posterior and central wall of the glenoid is essentially gone. And we went ahead and used an augment to make up for the missing bone and went ahead and fixed that down. So I thought I'd show a video here of a revision case. This is one of the more complex ones. This is a 74-year-old gentleman. He had 6 shoulder surgeries elsewhere, including multiple debridements for infection. So I resected him, placed a spacer, and then what we did is we went ahead on then and wanted to go to the revision. So here we are at the time of the revision. We'll go ahead, place the pin in there, and then what we're going to do here is we're going to ream the bottom part of the glenoid to 50% roughly. So what we'll do is be able to go ahead and ream that, and then we'll be able to go ahead and start preparing for the augment. So what we'll want to do is to make sure that we prepare it and place it in the same rotation. So we'll go ahead and drill for our alignment hole. Then we'll put the ream guide down. And what we'll do next is secure the ream guide to the bone with a screw. We want a stable platform to be able to do this. And for me, this is efficient, and I don't have to worry about graft resorption as we've had to worry about in the past. So we'll go ahead and use a screw. We'll tighten that down. And once the guide is flush with the bone, we stop turning the screwdriver. We make sure we're nice and flush there. After we do this, we'll put a little black cap on there, and we'll be able to go ahead and slide the reamer on top of that. So I think having proper retractors is helpful. You can see a bend home and above. We use a Batman retractor in the back and the front. We use a Derrick retractor on the bottom. And we've reamed the glenoid. You can see we've really not gotten into any cancellous bone. We preserve the cortical bone on the top. The glenoid is very precious. There's very little of it, so we want to preserve as much as possible. So that's what it typically looks like there. We'll go ahead and we can go ahead and use a trial to put it on there. It sits nice and flush on the prepared surface, and then we'll be able to go ahead and pound the base plate in there and then be able to go ahead and fix that down. The fun thing about shoulder surgery is that there's no lack of controversy. That's what makes this so much fun. There's no right or wrong way to do this, and it's sort of like base plates. I like to use a base plate with the center screw to be able to get compression that way. Other surgeons like to use base plate with a long post. It's whatever you would prefer that way. My own preferred way to do it is to use a center screw, and that way that I know that I have compression. I think once you see the base plate moving as a solid unit with the scapula, for me, the key at that point is the operation is almost essentially done. So that for me is the key step as a part of this. I think hypotensive anesthesia is really important. I've been fortunate to do a couple traveling fellowships. One thing I really learned by going around the world is if you have hypotensive anesthesia, it really minimizes the bleeding in these complex revision cases. So you can see the whole base plate and scapula moving as a solid unit. We put that down to make sure the screw is down all the way. And then I'll typically go ahead and just put locking screws in there, use 4 locking screws. And then on the glenoid side, what I'll do then is I will titrate the glenosphere just to be below the bottom part of the glenoid. So you can see we've placed this base plate in there, and we'll titrate the glenosphere down. We used to max that out to prevent notching. I think what we've learned over time is we don't have to do that. You just need the glenosphere a few millimeters below the bottom part of the glenoid, and that's what we'll do. The other thing we do on the humeral side, I really like to avoid cement. So we'll do most of our revisions in an uncemented manner. So I think at the end of the day, if you're going to do revisions, I think knowing the type of the components you're going to remove will helpful. And I think both on the primary and the revision, understanding that RSA angle will improve your chances of success as well as allow you to preserve glenoid bone. Thanks so much for the opportunity to present this morning.
Thank you, John. Thank you very much. You highlighted a very important point in reverse shoulder arthroplasty, the preservation of the glenoid. I just want to ask you one question because we have to go quickly here. But the question would be just for the follow-up. This looks like a wonderful idea, even better than we have think all the time and that we do practically every day to just do the eccentric reaming, but this idea of putting some metal to lateralize a little bit the glenoid looks wonderful, even with the medialization, with the option of medialize the humeral component. But I would like to ask you if you have some follow-up or a difference in clinical difference between these 2 or 3 groups of possibilities of preserving bone loss in your series, please.
Yeah, Juan Carlos, it's a great question. And, you know, it's interesting. I think one thing we've learned, I think the paper from the Rothman Institute was very powerful, because when you had surgeons like Jerry Williams, Matt Ramsey, others saying, look, bone graft is failing in 25% of our reverse cases when we bone graft. Then you saw that from my partner, Dr. Sanchez Sotelo, who led that paper, 20% failure with bone graft. Then you get Brad Edwards, very experienced surgeon, 1/3 of cases with graft resorption. I think the data from surgeons around the world is bone graft does not universally work in reverse arthroplasty. So I think that's a new concept. I think many of us were under the perception that it works 100% of the time. I don't think that's true. And I think the data is starting to mount on the problems with bone graft. And when I talk to my hip and knee colleagues, you know what they say? We told you that. We told you that's what you were going to see. And now the data is coming out. So I think the data really is coming out that way, Juan Carlos. So I think for me, the trend towards metal, it's simple, it's reproducible. I use it in all my reverse cases, primary and revision. And I think that's the trend we're starting to see now.
Okay, John, thank you. Thank you very much. Very, very nice talk and very in the cutting edge of the situation. Thank you very much. Daniel, please go ahead.
Thank you, John. Our next speaker will be George Athwal. You all know George. He has more than 200 scientific publications, more than 40 chapters, different books. He's from London, Ontario, from Canada. He will organize the next International Congress of Shoulder and Elbow Surgery after Rome. So he's one of the stars of the shoulder surgery nowadays, and we are very excited about his presentation. George?
Thank you, Juan Carlos. Thank you, Danielle, for that wonderful introduction. The check is in the mail. So I'm going to be speaking on fractures and non-unions of the scapular spine after reverse shoulder arthroplasty. I hope my volume is coming across well. I apologize if you hear my puppy barking in the background. This is my disclosure. This is all available on the Academy website. So really over the next 10 minutes, we're going to focus in on 4 particular areas of this presentation. I'll just go briefly through the background of scapular spine insufficiency fractures, the etiology, the management, and then if we choose to fix these, I'm going to present to you some of my surgical tips and tricks. So what are they? When we think about scapular spine insufficiency fractures, what we think they are now in 2021 is we believe it's a stress fracture. It occurs with repetitive loading at submaximal loads of the bone. So you get microfractures on the tension side of the bone. And eventually, once the remaining bone and the load applied exceeds the ultimate strength of the bone, you get this catastrophic fracture. And I have to tell you, this is what we believe they are, I think, but we're not absolutely certain this is what they are. So this is an FEA analysis that we did looking at the scapula and scapular spine, and we're going to go ahead and simulate that. So this is the deltoid load, and what you can see is that the acromion and the scapular spine is essentially like a diving board, and as the deltoid is pulling down on that lateral aspect of that, you get force concentration, which typically occurs in Levy zone 2 right here. And if we take a closer look at that, what you see is when we're applying the load, and these are loads that are submaximal failure, so below the ultimate failure strength of bone. And once we obtain these loads, you can get a microfracture. And as long as the loads continue and are occurring faster than our ability to heal the microfracture, you get more microfractures. So you can see repetitive loading, this is suboptimal loading. And eventually what's going to happen is the strength of the remaining bone, you're going to apply a load that's going to surpass that ultimate strength of the remaining bone, and then you'll have your catastrophic fracture that occurs at sub-ultimate loads. And this can occur in this direction, but it can also occur in other directions, means that we have microfractures that are occurring through the bone. And now what happens if you get an abduction and impingement of the greater tuberosity against the acromion, as long as the force of the greater tuberosity impinging against the acromion is greater than the strength of the remaining bone, you can also get a fracture that then propagates in the opposite direction. So these are some of the potential mechanisms of how we can get these acromial insufficiency fractures. Now, what causes them? Really, these are all theories. It's unknown. We believe it's probably multifactorial. We know that deltoid tension has something to do with it. We believe that implant characteristics are also important. We know that excessive glenoid lateralization, I use the term excessive glenoid lateralization, does increase acromial stresses. There's also theories out there that screw stress risers, applying a superior screw into your base plate, may potentially increase the risk of this. I can tell you certainly that there's no definitive one reason that these things occur. These are likely multifactorial. Looking specifically at some of the risk factors of what patients get these, patients, female sex, patients with osteoporosis, inflammatory arthritis, they typically have osteopenia, cuff tear arthropathy, patients with massive rotator cuff tears, and chronic dislocations. And this is some information provided to us from the ASCS complications for her shoulder arthroplasty research group, and they published a paper on this. So how common are they? If you look in the literature, it's quite variable, anywhere from 1 to 15%. This is a slide that was given to me by John Levy. The ASCS put together the research group, and in the research group, they felt that the overall complication rate of this occurrence was about just under 4%. Now, if you look at that paper, this is actually a very good, interesting paper looking specifically at this complication. And they felt that 3% of them were actually acromial fractures, about 1% were scapular spine fractures. On average, they occurred about 8 months after surgery. About 80% of them occurred within the first year, and 20% of them had a traumatic onset, meaning that the final catastrophic fracture occurred with some sort of high energy or moderate energy type event. Now, moving on to making the diagnosis, which is very important. The number one symptom for me is pain. I think that's number 2 and number 3. These patients have a honeymoon period, they're doing very well, and all of a sudden they come back to you at 3, 4, 7, 8 months after surgery, and they have pain again. But the pain is in a different location. These patients typically describe pain along the superior aspect of the shoulder. So that, along with any sort of decline in function or tenderness palpation, for me, is a scapular spine insufficiency fracture until it's ruled out. So I look for these injuries. So how do I look for them? I start off with physical examination. They're tender over that area. Even the skin sometimes is tender in these patients. And then start with imaging. Many times in these early stress reactions or early microfractures without displacement, x-rays are not going to help us. So it can be very difficult to identify these. So I have a very low threshold to go to a CT scan. But certainly on x-rays, there are also indirect features. This is a slide that I borrowed from John Levy again. If you look on the x-ray on the left at 7 weeks postoperative, and you measure the distance between the acromion and the implant, and then compare that to 3 months after surgery, you see that that distance is now decreased. So this indicates that there has been some shift in the scapular spine of the acromion. So there's likely a fracture there that's slowly tilted over time. Although we can't see it, we know it's there through these indirect sort of radiographic findings. So for me, I don't hesitate to go to CT scan. Any patient that has pain and tenderness in the scapular spine area after a reverse gets a CT scan, and I like a 3D CT scan. So as you can see here in this case, you can identify the scapular spine insufficiency fracture. So this is a patient of mine, 78 years old. I did a bio-RSA in her, and she came back at 3 months with acromial pain. So for me, this is a scapular spine insufficiency fracture until ruled out. You look at her x-rays, it looked good. However, you get the 3D CT scan, and you can see there is a minimally displaced scapular spine insufficiency fracture. So I managed her non-operatively, and she healed up. So there are several different ways to classify these injuries. My preferred classification is the Levy classification, and it really relates to how much of the deltoid insertion is involved with the particular fracture. So we have type 1 fractures that only involve the anterior and middle portion of the deltoid. The type 2s involve the entire middle and a little bit of the posterior deltoid, and the type 3s involve middle and posterior. And these are basically your basal scapular spine insufficiency fractures, the type 3, which tend to be bad actors. So now let's get to the controversy, the treatment of these sorts of injuries. So with type 1, that's the acromial type fracture. In general, if it's non-displaced, I manage these non-operatively. I rest them. I put patients back into an abduction sling for 6 weeks, ask them to avoid anti-inflammatories to hopefully to get this to heal. Now, really, my management of the displaced type 1 is the same. Right now, based on almost no evidence, I'm treating the type 1s non-operatively. But this is in 2021. What's going to happen in the future? I don't know. We may identify in a year or two that maybe we should be fixing type 1s that are displaced. But right now, my personal preference based on level 5 evidence is to treat these non-operatively. Now, what about type 2s and type 3s? Recently, I started to treat these the same. So if I have a non-displaced type 2 or type 3 fracture, I treat those non-operatively, but I follow them very closely. I follow them weekly. I want to ensure that they do not displace. Now, if we have a displaced type 2 or type 3, and this is where it gets controversial, you can treat these non-operatively. If you look at most key opinion leaders, they're recommending non-operative management. I may differ from that. I find that with non-operative management of displaced type 2 and type 3s, there's a high rate of non-union, over 80%, which was recently reported, pain and poor function. So if I have an acute displaced type 2 or type 3 fracture based on level 5 evidence, so I have no evidence to tell you this is the right thing to do. So this is just what I do. So I'm not preaching that you should do this. This is what I do now based on my personal preference, is I try to fix these, and I try to fix them sooner than later. I don't like them to go on to an established non-union because they're much harder to manage. So I manage these with acute open reduction and total fixation. I offer that to the patient and then let them decide what to do. So if you choose to manage these with open reduction and total fixation, these are some of the tips and tricks that I use. The first thing is if you're going to offer them surgery, do it quickly. Fractures heal better than non-unions. So don't wait for it to become a non-union. If you're going to operate on it quickly. The second thing is don't aim for a complete reduction. If you aim for a complete reduction of the scapular spine, you're going to recreate the stresses that caused the scapular spine fracture. So you're going to either get failure of fixation, or you're going to get another fracture that occurs medial to the plate. So I under-reduce them. So if you look at this x-ray, the plate is subtly bent, so the overall scapular spine is slightly under-reduced to decrease the tension in it, to hopefully decrease the risk of fixation failure and increase the risk of union. Use lock plates. John said that bone in the glenoid is at a premium. Bone in the scapular spine. The scapula is a challenge. The glenoid's a challenge. The scapular spine is a challenge also. The bone in there is at a premium. Use a bone plate. So this is, if I do get to a non-union, this yellow box here represents, you can't see it well, but it's a tibial allograft strut that Dr. Bernie Mori taught me how to do with the elbow. So I use this in the shoulder also. I'll screw that strut in there to provide orthogonal fixation. And then other fixation constructs are double plating, which I'll talk about in the next couple slides, and also using a hook plate construct for the scapular spine. So let's talk about double plating. This is a paper that was published, a biomechanical paper looking specifically at scapular spine fixation. They compared a single subcutaneous plate to double plating, as you can see here on the right. The take-home message is, if you have normal bone in the scapular spine, doesn't make a difference. If you have an osteopenic scapular spine, double plating is significantly better than single plating. And most of our patients that have scapular spine insufficiency fractures have osteoporosis. So if you're going to try to fix this, double plating is a reasonable approach to take. This is a 75-year-old male, 3 months after surgery. You can see he has a very lateral type 2 fracture, a very tilted acromion, as you can see here. He had poor function along with a chronic AC joint separation, which may have been part of the reason that he got the scapular spine insufficiency fracture. I managed him with double plating, as you can see here, and he healed this. This is an acute fixation. Now, what about a hook plate? This is a paper we published in JSCS just this year. We compared 4 different constructs for management of scapular spine insufficiency fractures. Type A construct was plating modular subcutaneous on the scapular spine, followed by in the fossa of the supraspinous. B is just a superficial plate. And type C and D are the addition of a lateral fixation feature, which we called a hook. And that's what it looks like. There's a hook. Typically, with these more lateral fractures, fixation in the acromion is challenging. The bone is thin and it's challenging. So what we added was this hook to see if it would help us. And so this is basically our survivability curve. And what we found is that a dorsally subcutaneous applied plate with a lateral fixation feature had the best fixation for these scapular spine insufficiency fractures. So here we have 2 cases. The case on the left represents a Levy type 2 acute fracture that I managed with a lateral hook plate, and the x-ray on the right represents a Levy 3, so it's a basilar fracture. So now when you have a basilar fracture, the limited real estate and a challenging bone stock is now on the medial side of the scapula. So you can see that there's a hook now on the medial side to hopefully enhance that fixation. So in summary, we've talked about this, and that's kind of the theme of the whole conference, is that complications happen. Right now, scapular insufficiency fractures are a little bit of a mystery to me, and I think hopefully in time we'll be able to determine how they and why they occur and prevent them. Right now, there's limited evidence on what to do. My personal preference based on level 5 evidence in displaced type 2s and 3s is to offer them surgery. I offer that to them early rather than late. I do an incomplete reduction, and then I augment with either a bone plate, a hook plate, or double plating. Thank you so much for allowing me to share some of my experience with scapular spine insufficiency fractures.
Thank you very much, George. It was an amazing presentation. Let me ask you, from the experience that we got dealing with os acromiale, you know that we use generally bone graft. Do you consider using bone graft when you go to surgery to treat these kind of complications?
Yes. So if I offer them surgery acutely and it's a fracture, in those cases I typically do not do bone grafting. However, if it's a delayed union or a patient that presents with a symptomatic non-union, I do bone grafting. So I actually still do iliac crest bone grafting, and for them I fix them lateral decubitus so I can get at the iliac crest easily. I pack in some cancellous bone graft, and I'll augment with a bone plate as described by Dr. Mori, where I just use a tibial allograft strut, put some holes in it, and I use that for orthogonal fixation in addition to my superficial applied plate. So yes, I do bone graft, the delayed unions and the non-unions.
Thank you very much, George. We will go ahead with the next speaker. Our next speaker is Carlos Torrens from Barcelona, Spain. He is from the Hospital del Mar in Barcelona, and he has a very important experience, and we all know him very well. And we'll speak about a complication that is always a big concern for all of us as surgeons. Carlos, thank you for being with us, and we will listen to you and try to learn as much as possible.
On my microphone and then come back again. Okay, so thank you, Daniel, for inviting me in such this exciting meeting and allowing me to talk about what has been one of my topics of interest in research in the last years. So we're going to talk on some clinical aspects of Cutibacterium agnes. If you go through PubMed and see what has happened at the last 15 years, you can see that there's a rising increase of publications concerning Cutibacterium agnes. But beyond giving more clarity, I think that they have given more confusion to this topic. So within the next few minutes, I will try to answer some clinical aspects of the Cutibacterium agnes that have been the base of my research. So I think that all of us know that many patients and the primary arthroplasty surgery having in the deep tissues some C. agnes. And moreover that, we also know that phylotype 1b and 2, which have been considered the more important involved in infections of implants, are there after the first surgery. So the first question is, can C. agnes contaminating primary surgery be the cause of a periprosthetic joint infection? The second question I will try to answer is, do patients with C. agnes contamination have poorer outcomes? And I will try to end with some ideas about what is now something in debate, if the C. agnes is already present in the joint, or are the surgeons the ones who deliver the C. agnes in the joint. So first of all, can C. agnes contaminating primary surgery be the cause of periprosthetic joint infection? we did a study on that, and that was a prospective study. We involved more than 150 patients, all primary reversed. And in all of them, we took 5 to 12 cultures. And then the DNA was extracted from the C. agnes isolated in those surgeries. And the whole genome sequencing analysis was done. So we deeply studied the C. agnes present at the end of the primary surgery. 27 of the patients end up with C. agnes positive cultures, and 2 of them develop a periprosthetic joint infection caused by C. agnes isolated at the revision surgery at 6 and 4 months after primary surgery. The WGS of C. agnes isolated colonies show that all the revision surgery isolates cluster near to the corresponding primary surgery isolates when compared to other independent bacterial colonies, more than 99.89% of similarity, meaning that the C. agnes present at the end of the primary surgery were the same isolated once the infection was detected. This is the heat diagram of the WGS of the C. agnes, and it's really hard to see here in just one slide. What red means similarity, while blue means non-similarity beyond 99.4, and the ones present at the primary surgery and the ones present at the infection when it was revised were exactly the same. So in conclusion, C. agnes is present at the end of the primary surgery, can be the cause of early or delayed periprosthetic joint infections in shoulder arthroplasty. If you want to learn more about this, you will be able to see the full study published in the Clinical Microbiology and Infectious Disease. So you can read the whole paper. Going to the second question, do patients with C. agnes contamination have poorer outcomes? We all hear that having C. agnes may be something that can cause pain and stiffness, and that probably these are the main symptoms to detect C. agnes. So we did a prospective study including 162 patients, primary RSI. In all of them, we took 5 to 12 cultures again, and we followed these patients over 2 to 5 years. We took the constant score for the functional outcome, and we also take care of the complications that these patients presented over time. So 25 patients end up with C. agnes positive cultures, and we compare the results of the positive cultures with the results of the negative patients. So the patients having C. agnes were slightly younger, but I don't think it's of any clinical relevance. They were in poorer condition before surgery. So the ASA anesthetic value was around 3 compared to 2 in the negative patients. Obviously, most of them were males, the positive ones, and no significant difference were not in diagnosis, laterality, glenosphere size, approach, or if the prosthesis were cemented or not. The pre-op functional status measured with the constant score was exactly the same in both groups. And when we look at the post-op at 2 years and 5 years, there was any significant difference in the total constant score, no difference in pain, and subclinical difference in rotation at 2 and 5 years. So I can say that probably there are no clinically relevant difference between the patients having C. agnes in the deep tissues compared to those not having C. agnes. But it's interesting to see that the complications that we had in this series, all of them recall in the positive group. So We had 2 infections, 1 revision surgery because of pain, and 1 dislocation. So all the complications we saw were in the positive group. So in conclusion, no significant differences can be expected in functional outcomes between patients having C. agnes and those not having C. agnes, but be aware that a higher complication rate will be found among the patients having C. agnes. And just to end, we've done recently a study to assess if we inoculate C. agnes from the skin. And we have done a prospective study including 55 patients, all from primary RSA, and we took 9 cultures, 3 from skin, 3 from glenoid, and 3 from the humerus side. And in the same way, we did DNA extracted from the C. agnes isolated colonies, and we did the whole genome sequencing analysis of all these C. agnes. And we found that among these 55 patients, 6 had C. agnes both in skin and in deep tissues, and that the WGS of the C. agnes isolated colonies showed that the skin isolators were exactly the same that the deep tissue isolators. Once again, this is the graphic when you can see in the middle that all of them were exactly the same, meaning that we are, as surgeons, the ones delivering the C. agnes from the skin to the deep tissues. So probably we can consider, or we may consider, to change prophylaxis or skin preparation of our surgery, because C. agnes can be brought from the skin to the deep tissues by the surgeon. So in conclusion, C. agnes is present at the end of primary surgery, and it can be the cause of early and delayed periprosthetic joint infections. We may not find significant difference in functional outcomes between patients having C. agnes and those not having C. agnes, but be aware because we will find a higher complicated rate of complications. And C. agnes in skin will be delivered to the deep tissues by the surgeon, so probably we need to address this prophylaxis and skin preparation issue. Thank you.
Thank you very much, Carlos. Very interesting. I would like to ask you, what do you advise to prevent complications with the C. agnes?
I don't think I can give you an answer right now. We are working on that, but it's really complicated because antibiotics use are not as good for C. agnes as they were for staph, for example, and skin preparation is not as good for C. agnes. But some studies have shown that maybe other skin preparation like benzoyl peroxide or something like that can reduce the number of C. agnes, but none of them have shown that this has an impact on infection. So it's just that the C. agnes is reduced, which is something important, but we don't know yet if they reduce, let's say, phylotype 1A instead of phylotype 2. So there's a lot of knowledge still to come.
Thank you very much, Carlos. Juan Carlos, we will go ahead with the next presentation.
Thank you, Danny. Yes, thank you, Carlos. Wonderful talk, Thank you very much. It is my pleasure to introduce to you Dr. Fernando Valero, to who I'm known for many years. I remember you very much, Fernando, with the times of our good friend, Dr. Gutierrez from Mexico. So it's wonderful to see you here. Dr. Valero is the chairman of the reconstruction unit in the Hospital Ángeles del Pedregal in Ciudad de Mexico, and he's a member of our Latin American Society as well as the Mexican Reconstruction and Arthroscopic Society, and as well as the American Orthopedic Society of Orthopedic Surgeons. So it is a privilege again to present you, Fernando. Is there something wrong with the RCA? ¿Hay algo malo en la cirugía de prótesis reversa? Por favor, adelante. Thank you very much.
Thank you, Danny. Thank you, Juan Carlos. It's a pleasure for me to stay with you. Okay, first, my sins. I am enthusiastic about the shoulder arthroplasty. I am a critic of status quo of the practice of the orthopedic surgery. I am a Raiders fan, ever in Las Vegas, and apologize my terrible English. Is there something wrong with the RSA? Maybe these people have a different opinion. However, I consider that we must stop to reflect. This paper of Ron Navarro shows us the dramatic race of the shoulder arthroplasty with the reverse, but still the arthroplasty, the reverse shoulder arthroplasty, have more than 20% of the complications. What the reasons? Is so many indications. We are misuse of the recourse, or the notching is the big problem. The surgeon is the problem. The number of implants is the problem. Remember Paul Gramont, and he gave us the principles of the successful reverse shoulder arthroplasty in 1993, but the reversomania is a problem. It's a big problem. In 2011, 33% of the papers talk about the reverse shoulder arthroplasty. In 2019, 70% talks about the reverse shoulder arthroplasty. I ask me, is those Paul Gramont dream it? Indications, talk with the indications. The main indication of the reverse shoulder arthroplasty is a cuff tear arthropathy. But now, if you see this paper of the 2050, the use of the reverse in the United States and all the world is this. But I only find 2 articles, 2 papers to talk about the results about or according to each diagnosis. The results of this, the conclusion of these papers is that the best results is with the reverse in the cuff tear arthropathy, and secondary in the shoulder osteoarthritis. The notching. Paul Valero said it's not a complication. I agree, I strongly agree. The knowledge of the implant techniques and the philosophy decrease the incidence. I only have 1 revision by notching in my cases. Why? I early learned that the inferior bony overhang of the metaglene, the tilt, the 10 to 20 in the middle of 15 degrees, I incorporate really the RSA angle of below, and when the neck of my patient, of the glenoid neck, is less than 9 millimeters, I do a bio-RSA. I currently have 1 patient with notching in a lateralized implant. Is a problem of the implant? No, it's my mistake when I place this. This is the case of the lady with the notching I revise. The problem with this is that she don't accept. He refused the total revision. I only changed the polyethylene. You can see the polyethylene is a retentive polyethylene. I changed by no retentive 2 years ago, and the patient is okay until now. For me, the notching is a surgeon problem, not a design or an implant problem. Who is doing the reverse shoulder arthroplasty? According to some papers, the 75 are performed by surgeons who implant less than 5 prosthesis by year. The vast majority of these without a real proper training takes about the fellowship. In Mexico, the problem is greater than it may not be different in the rest of Latin America, I think. I'm not sure. Therefore, the percentage of the complications such as this continue to be high. Show the picture. This is a patient who have a surgery outside the Mexico, and you look, the metaglin and glenosphere is implant in the coracoid. This is only a knowledge of the implant. If you see this, this is another case with the implant is not correctly implanted. And this is a young surgeon with the first reverse, a revision. It's not correct to do that. But if you have you not only have the know about the implant this reverse shoulder arthroplasty, you need to have the tools to resolve the complications. When we have this patient, this design, the compressive system is not in Mexico. We need to resolve the problem, and we resolve with this, and this is the X-ray 4 years after. The learning curve is a hot topic. If you review the papers talks about the experience, the volume, the number of cases per year, but the really is that no are agree in between the surgeons. This paper of 2011 says the magic number is 40 will be adequate. I think there's 40 or less is enough, but a surgeon will do routinely shoulder arthroplasty. But if you don't are this kind of surgeon, maybe you need more supervised surgery to have a qualified surgeon. Where do they learn? Now the shoulder is a fashion joint. Everybody wants to do a superior capsular reconstruction or a reverse shoulder arthroplasty. That is not enough programs. You have alternatives, short observerships, cadaver labs, dry labs, but the majority of the young surgeons goes to the less suitable alternative. It is practicing saw bones and go to the operation room, means the complications. Where did they train? Without proper training, they will hardly understand the variations of each system or the change made to provide the final result. Now, the shoulder surgeons talk about the low offset, high offset, global offset, humeral offset, medially side, lateral side, global lateral side, different kinds of osteotomies, different kinds of necks of the implants. You need to understand this for have a successful arthroplasty. Do we need so much? In 2016, 30 different designs brands exist, but the last week, 10 new designs have the kickoff to go to the market. Have a good reasons for this. The new designs correct the previous defects, simplicity of the techniques, and maybe are cheaper the arthroplasty, but it's not true. They only change one problem, but other problems, the new technique is no results of the problems and limit the doctor to the degree of implanted. The cost is not cheaper. is because the new technology is more expensive. A perverse cycle is established. As with the anchors, our arthroscopy techniques continually changing and quickly make what you have obsolete. We are real evidence in the effectiveness of the benefits of the new implants. Finally, my perspective is this. The RSA is one of the most useful contributions in the last 20 years. However, a high percentage of these procedures are carried out by inexperienced hands. In the absence of the formal learning process, the work of instructor and training surgeons have been left to the commercial houses, who, instead than teaching, they indoctrinate the surgeon and implant or philosophy, not always true, not always applicable to all cases and diagnoses. For a surgeon who, like me, has to deal with the unsatisfactory results of these surgeons and those teachings of the industry in his day-to-day life, it is a motive of concern. To remember, who sows arthroplasty harvest reviews. It's always better. Thanks for the opportunity to stay with you, my fellows.
Thank you, Fernando. Thank you very much. You really pointed out a really critical situation that we all see in our practice. And you make us think all about the use of reverse shoulder arthroplasty. I thank you very much for that talk. It's very important to, as you said, stop a little bit and think about the real indications. Let me ask you just one question, because we have to continue. And Daniel, I think we have been on time, and we are close to an hour, and then the next session will begin. So Fernando, there is a controversy in the literature, and actually in our hospital also, we discuss about the indication of reverse shoulder arthroplasty for primary osteoarthritis in patients over 70 or over 75 with rotator cuff intact, with an intact rotator cuff. That is everyday controversy. The anatomic shoulder replacement I think is wonderful for patients with intact rotator cuff, even if they are 75 or more, for primary osteoarthritis. But of course, there is a trend, as you said, to use reverse even in those cases. What do you think about reverse shoulder arthroplasty for older patients with primary osteoarthritis with intact rotator cuff?
I continue believe in the anatomic shoulder arthroplasty. Is the results of an anatomic shoulder arthroplasty in osteoarthritis is better than the reverse. What's the problem? The people over the 70s want speed in his recuperation, and yes, the reverse
gives you that. Yes, exactly.
And this is the reason. I like you see, the 70 of my arthroplasty are reverse. I do 30% of anatomical. I believe in the anatomical reverse. Yeah.
Okay.
Daniel, can I just make one question in the continuity to Dr. Valero?
Yes, of course.
Okay, Dr. Fernando, I've been thinking about Juan's, Carlos' question for about 8 or 7 years now, because if in one hand you have a good cuff in a 72, 73-year-old lady demanding a TSA and not a reverse, on the other hand, in a few years, this cuff can go very bad, demanding hence a revision. So having said that, don't you think that it would be safer to go straightly and primarily for a reverse in a way that you will much probably not much probably not need to do a revision, I would say, in the following 10 or 15 years. I think that that would be quite rational. So if I have a patient 70 plus, even with a good cuff, I would be very afraid of cuff deterioration over time, even if you put a well done anatomical arthroplasty. In this sense, I would feel much safer to go straightly for a reverse. They are low demanding, and if their reverse lasts 15 years, this is going to be a good result from 72 or 75 to 87 or 90, which means until the end of the patient's life. So in this sense, don't you think that it would be wiser to go straightly to a reverse in spite of the still integrity of the posterior superior cuff?
Yes, but I don't know what the situation in Brazil, but we have people over the 70s that continue do sports, physical activity.
Sure.
And this kind of person is not a low demand patient, it's a high demand patient.
Mm-hmm. Sure.
And have strong tendons of the cuff.
Mm-hmm.
I don't like to put in these patients a reverse.
Mm-hmm.
I prefer in these patients put anatomical. But
Okay.
you have a reason. If in the time, in the evolution, with the pass of the years, the cuff can be deteriorate. Yes. But
Sure.
when you propose to the patient, I say, this is vanilla and chocolate.
Yes.
What do you want?
Yeah.
These have these pros and these have these pros. What do you do? What do you need? What do you prefer? And
Sure.
the patients take the decision about this.
Lovely. My last
This is
question.
for my practice.
Thank you, Sergio. Thank you very much. We have a couple of questions from the audience. One of them is for Sean. Sean, can you hear me?
Perfectly.
Good. There is a question. When do you consider that the bone graft has failed?
Yeah, it's interesting, Daniel. We've seen a number of these cases where the bone graft actually fails later, 1, 2, 2.5 years out. So I think that's another concerning thing that we've seen on the graft side is late failures associated with them. But these are patients that we follow along that way, and particularly on the revision side with good fluoroscopically positioned x-rays and CT scan if necessary. But I think being aware of late failures with bone graft is important to know as well.
Good. And there is a second question. Do you always use, even in revisions, you use non-cemented prosthesis?
Yeah, it's interesting, Daniel. We had one of our fellows, Eric Wagner, great person. He looked up, he did 2 papers for us, which I think changed our practice. One is that on the revision, Daniel, if I remove a 122 millimeter stem, I actually use a short stem, 83 millimeters or 55, so we don't bypass it. So when I do revisions, we go shorter and shorter, not longer and longer. So I avoid using long stems basically at almost all costs. So we have many cases out there where we have a short stem, air, and the old pedestal. We do not bypass it. The second thing we've learned, Daniel, on the revision side is the cement within cement technique, which can be extraordinarily helpful. So if you have a cemented hemiarthroplasty, what we'll do is remove that stem and we'll go for a shorter and thinner stem and cement within cement, just like our hip colleagues have done for many years. And that makes revision surgery so much nicer. I have several friends, unfortunately, use the ultra drive device to remove the cement, and you can burn the radial nerve with that. So, yeah, so the key is cement within cement makes the revisions go quicker and easier. The second thing is that go long to short. And then the third thing, then I'll stop. If there's a long plate in there, what we'll do sometimes if the patient gets avascular necrosis, take out the top screws, leave the entire plate on there, and then put a little short stem in. So you don't have to strip the deltoid and do all that. So a couple tips and tricks that may help you on these complex cases. Thank you.
Thank you very much. There is a question for Carlos Torrens from the audience. Carlos, do you ask to your patients blood cultures to check if they have in blood the bacterium?
We routinely take cultures at surgery, but we don't do any blood test to detect C. agnes.
Thank you very much. Well, we have finished this first block. We have two cases to discuss. So now, Juan Pablo and Sergio, you are in charge. Thank you very much to all.
Lovely.
Thank you very much.
Very good. So who is the first one to start the first case, Daniel? I don't know.
Diego.
Yes, I guess it's me.
Okay, good.
Okay, so are you ready?
Thanks, Diego. Diego works at the Hospital Británico, British Hospital in Buenos Aires. He's a very well-trained surgeon. He's one of our shoulder promises in Argentina. It's a great pleasure having you, Diego. Let's go ahead.
Okay, thank you so much. Sorry. Okay. Well, hello, everybody. I would like to thank Juan Pablo, Daniel, and Sergio for the invitation. It is a pleasure and an honor for me to be here with all these stars of shoulder surgery. I want to show you a case of a 72-year-old right-hand dominant male who sustained a complex proximal humerus fracture after a ramp level fall. We can observe some severe comminution of the tuberosities. Therefore, we decided to perform a reverse shoulder arthroplasty. We were satisfied with the results with an adequate reduction of the tuberosities, perhaps an excessive extension of the cement with some mistakes of the cement technique. 3 years later, he was quite pleased with the result and the treatment, but with an acceptable mobility. He had 120 degrees of anterior elevation. He had some radiolucency on the lateral aspect of the humerus and a malunion of the tuberosities. However, he had a good external rotation. We lost track of him during the pandemic, and he came back to our office 3 months ago after suffering a new ground level fall, playing with his grandson at home. And we observed in the X-ray a periprosthetic humerus fracture with significant thinning on the lateral cortex of the humerus, as well as a fracture of the cement mantle. We consider the glenoid implant to be fixed and well positioned. So I would like to hear your opinions, Juan Pablo, and your questions regarding the classification, the bone quality, and the stability of the implant. Sorry, I think you're on mute.
If you can stop sharing the screen, Diego, maybe we can ask the panelists about this. Because
okay.
I would like to hear all these experts talk about this. Maybe John, what are your opinions on this type of fracture? I mean, beyond classification, because I think we all use the same classification, the one that's adapted from hip literature.
Yeah.
What do you look for in these fractures? What are your things that you look for to know what to do with these patients?
Yeah, so in this case, it looks like it's I use the Cofield Wright classification type A that from the tip extends proximally. It's a spiral fracture, and there looks like there's associated humeral component loosening as well. So for me, if this one is one for me that I would look towards operative intervention on. Some of them, if they're more distal fractures, the well-fixed stem, some of those will heal a type C. They heal like a spiral fracture of the distal humerus. Or mid-humerus, you can consider non-operative treatment. But for me, I'd be more inclined towards operative treatment. But I look forward to hearing what others think.
All right. Anybody else from the panel? George, what do you think?
Yeah, so I use the Vancouver classification. So this would be a B3. It's fracture with bone loss. So it's not uncommon when you have resorption of the tuberosity with a cylindrical stem to get aseptic loosening. And so this looked like that at 3 years, and that the tuberosity was gone. The rotational torques on the implant is what leads to this aseptic loosening, and then obviously had a fall and fracture. So I made the mistake in young people of treating this injury trying non-operative, and sometimes it heals, and so that's not good though. So when this heals, it heals with the shaft very displaced. He's 72, and then he's got a loose implant. So once it's healed and he starts moving, he has pain from his implant, and then it's a challenging revision because you have to re-break it to get down the shaft again. So if he's young and active, I would talk to him about both options, but I would lean towards surgery for him because it's going to be much easier to do it with the implant loose and it's fresh fractured now than later. And for me, this would be, I would try to wrap an APC, keep as much of the soft tissues, but it's probably going to be an APC for me.
Carlos, any other comments from your behalf?
I just, with any periprosthetic fracture, I just try to answer two questions. The one is it going to heal without doing anything else? And in this case, I don't think it's going to heal. And the second one is the prosthesis stable still? And I think that the cement is broken, so it's not going to be stable. So clearly we have to take it up and do something. But another thing I just wanted to comment is that right now, I think that there are at least 3 companies delivering stems that can be used for fractures without cement. And I think that choosing a stem is not a religion. And one of the things that have changed completely in my life has been doing fractures right now without cement in, because fractures are more commonly involved in periprosthetic fractures because they are in osteoporotic patients. And infection is also more common in patients coming from fractures. So it's really easy to deal with that without cement.
All right.
Good. Juan, can I ask one question to John?
Of course.
Okay, so John, the thing is, once you manage this operatively, rather with a new stem, a longer stem, or with a down miles plate or something like that, especially when we are talking about older patients, even with the presence of cement, if you do a down miles plate like people doing revisions in the hip, would you consider using graft? And if yes, what kind of graft would you prefer in such cases?
Yeah, that's what again makes this so much fun. People have different perspectives. So I would not do an APC reconstruction proximally in this patient. I would actually use metal. So again, I lean more towards the hip and knee side of reconstruction than the traditional shoulder. And I think we've seen some resorption of grafts. So graft availability, you have to get the graft just right. So it's kind of a technical challenge. Sometimes you have to cement the graft in the stem proximally, then distal, or you have to cable it, and then you have to hope that the alignment is correct. So actually, I would use metal proximally. That's what I would do rather than an APC. No right or wrong answer.
I know that's why I asked you, but the thing is, what's your experience whenever we think about the hip with the cables and something like the down miles plate? Do you think that it works in such cases, thinking about the hip?
Yeah, I lean towards the metal solution than putting huge amounts of strut grafts, cables. I worry about infection. I worry about the bone up there. So again, I lean more towards the metal side.
Okay, good.
Thank you. All right, Diego, do you want to go forward?
Okay. Okay. So yes, we thought similar. We also use the Vancouver classification, but as well the Wright and Cofield, which as has been said by Sean is a type A. And in this particular patient, considering he had a loose humeral implant, we decided to revise him. An extensive deltopectoral approach was used. The fracture lines were identified. And of course, it's mandatory to identify and protect the radial nerve. In this case, the stem was grossly loose, so it was easily removed. And in an effort to respect as much muscle attachment as possible, we kept the insertion of the latissimus dorsi and the pectoralis major, considering what George has said about losing the greater tuberosity. So in the blue circle, you can also look that there is a big area of comminution of bone loss, which makes impossible a complete reduction of the fracture. So at this point, we decide to use a long stem cemented, bypassing the fracture. But we have another question here, because it is, I think, an important consideration. You need to know that here in Argentina, we don't have all the options you have over there. So we need to plan very well what we're gonna do. And as it is known, you need to have at least 2 or 3 cortical diameters of distal fixation with this kind of prosthesis. But the longer revision stem available in Argentina for this company is 17.5 centimeter, which allows us a distal fixation between 1 and 2 diameters. So I would like to know your opinion. What would you do about this?
All right.
Pablo?
Yeah. So let's go back
to
the panel discussion. That if there is insufficient stem length, would you add anything else to your construct? I mean, if this is the only thing you have available, what would you do in Diego's position?
So I think one thing to know is always helpful in these complex situations. What are your options available with the components that you have? So on the glenosphere, is there a thicker option? Can I dial the glenosphere down? What are my humeral tray options? And I think knowing this both ways, I'll give you an example. As you know, Juan, we have a lot of total elbows done at the Mayo Clinic, right? And I've had some where they put cement all the way up the humeral shaft on a patient, all the way up. And then you have to think, well, how am I going to manage this on the reverse side? On occasion, I'll take the glenosphere, and just to get a few millimeters below the bottom part, I actually dial the glenosphere up, believe it or not, to create space. So you start thinking over time, what are the options I have? So I would understand, what are my glenosphere options? What are my humeral tray options? Can I sink it a little further, build it up on the glenoid side, build it up on the humeral side? Just a few thoughts.
Yeah. Just to clarify, we do have some options. It's not the only option. I was wondering, what is the ideal length you consider is enough in this situation?
All right. George, any opinion on ideal distal fixation length?
Yeah, I mean, it's going to depend on, oh, sorry, go ahead.
No, that's a very good question. So please answer that, George.
I mean, for me, it's going to depend on if it's a press fit or cemented stem. So certainly if you do have a press fit stem, as you can see, the humerus distally is funnel shaped. So the bone loss is below the level of the deltoid insertion. So your ability to get press fit fixations is probably only 2 centimeters anyways before it starts to dilate out. So if you can get a 1 millimeter increment press fit stem, that's what you're going to rely on to get the fixation. So then it doesn't matter. But if it's a cemented stem, a circular cemented stem, which most of the long stems are circular small cement, I would need 4 or 5 centimeters. So this would be probably unacceptable to me if this was going to be a cemented fixation. So I would have to, and if this is the only implant I had available, I didn't have an implant longer, I would then, and this might sound crazy, I might consider a staged procedure. I'd put an IM nail down and put some struts in, try to fill up the canal with the nail, get some struts to heal, and then take the nail out and put an implant in. But I must admit, I feel very fortunate that I have 180, 200, 220 millimeter implants. So I've not had the problem where I didn't have the implant size. So I apologize for that.
So George, just one question. Imagining that you would have all the sizes of the stem, in such a challenging case, do you have any parameter of how far you should go or you can go, something like the olecranon non fossa or something like that, in a sense that the longer the better? Do you have any anatomical parameter, or that would be a very difficult response?
I don't think I have an ideal number. I can't tell you it has to be 5 centimeters or 6 centimeters. For me, it depends on the type of the stem, the bone loss. So in this case right here, where you look in the lateral cortex where it says 4.4 and that proximal mark, I know the only bone I have is distal to that. So for me, this would be getting that stem down to the apex of the olecranon fossa for me.
Okay, good.
That's where I'd want it, because I would need that fixation. So I'm also very hesitant in doing, and And John's my mentor. I have to say that. I trained with him. He taught me everything I know. But I'm very hesitant in doing a press fit here and not doing some sort of bone reconstitution, because a press fit stem with that much fixation, if it gets loose, then you're done, right? Then you're a total humerus. So I would lean towards doing some sort of adding some allograft to it, so that I do have an option available too. That's just my personal thoughts. And I personally find it much easier for me to revise a long stem cemented than a long stem press fit. I find a long stem press fit implant, I destroy the humerus trying to revise it if it gets affected, versus a long stem cemented, I just do the anterior cortical window and it comes out very easy and I chip the cement out. So those are my personal preferences.
Okay, but in this case, this is my last question. The longer, the better, the stem, or is it not exactly like that? In this very challenging case, the longer, the better, or not exactly?
So for me, in this case, where the bone loss goes past the deltoid insertion, it's a full length. Yeah. So if it's proximal to the deltoid insertion, you have a lot of options. You can put a small stem in. Here, I don't think there's any bone left to put a short stem in. So the only fixation is distal. And so it would be a long stem for me, all the way to the bottom.
Thanks, George. Diego, show us what you did.
Yes,
please.
I agree with you. And considering this, we have the option to do a custom-made implant in a local company here in Argentina. So we decided to do this. It's a 20 centimeter, because this allows us to have a safer alternative in the scenario of having a loose stem. So we did as George just said, we put a long stem, we put all down the stem in the humerus, and we also add 2 partial cylinders of femoral allograft to form a sarcophagus. And I fixed both the struts with circlage wires for both structural and biological augmentation. So this is the 2 months post-op X-ray. Sorry, but the patient is really recent, so I don't have a long follow-up. I don't know if you have any considerations or critiques with this, George, Sean, Carlos.
Yeah, I think your reconstruction looks perfect. You got cement down at the bottom. The only thing I would have done personally different is I just used I asked for a full-length large male humerus. So I asked for the full, like a 55 or 56, 58 millimeter humeral head, full-length humerus. I find that, but certainly I think the strut reconstructions, I mean, your alignment looks great, your length looks good.
Yeah,
Let's hope it heals.
Diego,
Yes.
Diego, I have a very interesting question to you, and a very pedagogical one for all of us. I'm very curious. How difficult was it to dislocate the reverse, and still, did you change the pulley of the reverse, or you kept the previous pulley?
Well, it was not difficult because you had the fracture, so you need to use a bone hook or something to pull a little bit, and you remove the pulley, the liner, and after that, as the proximal bone was fractured, honestly, it was everything moving, so it was really easy to remove the cement as well. It all came out with your fingers, with the hand, and yes, of course, we use a new liner.
A new liner.
The humerus is all new. And the glenoid implant, it was fixed. We check it, so it's the same.
And the liner was exactly in the same size of the previous one, or it was bigger?
No, we had many options for that, and it was the same. It was not necessary to extend it.
Good.
Great. Thank you so much, Diego.
Okay, so just to show you the end, this is the video 2 weeks ago. He's recently started the mobility, so he's already moving 90 degrees of elevation in the cubitus position. He's painless and he has a good mobility for daily, everyday activities. So thank you so much, and that's it.
Well done.
Thank you, Diego.
Thank you so much.
Beautiful.
All right. Now we'll see our last case with Guido Fierro. Guido Fierro, he works at Fundación Bogotá in Colombia. Guido, thanks for joining us.
Thanks to you. Thanks all the panel for this kind invitation and for the opportunity to share this interesting case. This is a case for a lady that we all love in our section. And she's from a small town in Colombia. She is 57 years old at the moment when she came to us with pain. And this is the key of the start of the case, because she consulted in his small town, his family doctor, for pain in the shoulder. 4 months for pain in the shoulder. And what happened with a 57 years old with a shoulder pain? Of course, a rotator cuff problems. And she went to physical therapy. And after that, after many sessions of physical therapy, she is still with pain. And after that, the doctor said, okay, maybe it's time for X-ray, and look what she got in the X-ray. This is a really interesting X-ray, because with this X-ray, she went to the oncology center, because at the beginning, the cases, everybody thought that was cancer. And she went to oncology center, and the oncology center said, you know, this is not a tumor in the bone. You should go to the hospital. And then she came with us with this X-ray, and of course we ordered MRI with these results. I mean, as you can see here, she has a bone cyst in the humeral head. This looks like a fluid, but some more density than just fluid, with a severe compromise of the glenoid, and the rotator cuff was a tiny rotator cuff. With this situation, I mean, at that time was almost 5 months of pain in the shoulder. She referred that maybe she has some fever, but she cannot remember well what if she had or not fever. And the ESR and CRP was high. The neutrophil count was high too. And I mean, you're in the emergency room. What do you do? I mean, in this time of the case, I would like to ask to the panel, what would you do? I mean, with this lady in the emergency room in your hospital, maybe humeral head resection in the first time, or maybe some kind of debridement, arthroscopy, open the debridement. I don't know. What do you do?
Right. Fernando, Valero, how do you start this case?
First, with these symptoms, I prefer to do arthroscopic debridement, and first in this case first.
Yes.
Only an arthroscopic debridement is my choose, my selection.
Oh, okay, Guido. But the thing is, we have to understand, or we have to remember, that there is no proper management without a proper diagnosis. So I would be tremendously interested in this case in establishing the diagnosis. Again, I cannot make some treatment without a formal diagnosis. So this is a different case. I would definitely show this to a very good orthopedic oncologist and see if there is any other exam in the role, and maybe according to a very good guide to guide me until proven contrary, a very skilled orthopedic oncologist, maybe a biopsy to understand what are we talking about. Without a proper diagnosis, no proper management in gynecology or in orthopedics. So I would straightly go by in this sense. And in my opinion, it would be difficult not to go in this rationale.
Yeah, I would agree.
It's true. Actually, the first thing that I thought when I saw the X-ray was a tumor. And the resident told me, hey, Dr. Joe, she just came from the oncology center, and they say it's no cancer, it's no tumor. And that is the reason, because what I did was exactly what Fernando said. I performed arthroscopy shoulder debridement and took biopsy and cultures of this shoulder. And what we got was no evidence of neoplasia, means the oncology center was right. And the culture was 2 kinds of staphylococcus, and was an infection actually, and no mycobacteriums in the PCR. Okay, And with this situation, what do you do again? I mean, at that time you perform a shoulder, arthroscopic shoulder debridement. You took many pieces of the bone. In that surgery, we cannot find fluid. We find like a fibrosus tissue in the shoulder, and that's it. I mean, after that, what do you do? I mean, what would be your advice in these cases? Maybe just a humeral head resection, maybe antibiotic spacer, or maybe I don't know, a reverse shoulder arthroplasty at that time with antibiotics. I don't know. I would like to listen to the panel.
The only thing I would add, Guido, that what I would have done, I'm very similar to Sergio, that I think I probably would have felt more comfortable getting a diagnosis. So I would have done an aspiration. And typically I would have asked for tuberculosis, because this is weird, right? I would ask for tuberculosis. I would ask for infection work of fungus.
Yes.
I would ask for those sorts of kind of atypical things. I'd also get a medicine consult to rule out an endocrine cause, because you get endocrine things like, parathyroid that cause weird things like this. And then also rheumatoid arthritis. I find that you get cystic erosions, rheumatoid arthritis, and also pigmented nodular stuff, but that would have been on the MRI. But certainly for me, I would have been, I'm not as bold as you. I would have been a little more cautious and get some more tests before I would have jumped to the OR. But that's personally me. But maybe it wouldn't have made a difference.
Sure. Thank you. And we did. There was no tuberculosis signs in the cultures at the end.
Yeah, I agree with George. I would have done an ultrasound guided aspiration. And on occasion, I agree that sometimes in some rheumatoids, you do see that degree of destruction on the humeral and glenoid side. And then the other thing, anytime in the back of your mind, when you see massive destruction on the glenoid humeral side that are out of proportion to arthritis, in addition to infection, is the syrinx. So I probably would have gotten an MRI of her cervical spine, not to make sure she didn't have a syrinx as well.
I agree. I've had several of those cases, and they get the MRI, and there it is.
Yeah, but Guido, now I was telling you about there is no proper management without a proper diagnosis. And on the next step, now with the Mycobacterium, we have to formally confirm or exclude the possibility of being tuberculosis arthropathy. So in this sense, then I would go very objectively to talk with a good infectologist to see, so Mr. Infectologist, now what do we do to, well, there is Mycobacterium, until proven contrary, this is tuberculosis arthropathy, and it exists. I have seen 2 cases in the knee in my college 20 years ago in my residency. I don't have the answer of how to manage, but again, did you worried about being 100% sure if this was or not tuberculosis arthropathy?
Yeah, it's true. Actually, the interesting thing is we did all those things. She got MRI, a cervical MRI, and was fine. Just a little mild arthrosis in the cervical spine, and that's it. And the infectologist say, I mean, with all the tests for tuberculosis was negative. And no other pathologies in his joints. I mean, what was that it? I mean, this is an interesting case because about the fluid, because as I told you, in the scope we couldn't find a fluid. It was like a fibrotic tissue, was no liquid. Okay, that was the reason, because actually I did it before without ultrasound. I mean, in the OR before the scope, but was no fluid in the joint. It was like a fibrotic tissue inside the joint. Actually, in the scope, I couldn't see the glenoid surface. What we saw was like a fibrin tissue just above the cardiac of the glenoid. Was a rare case. Actually, and what we planned at that time was these things: a humeral head resection and an antibiotic proximal humeral space. That was our plan, and we did. Actually, we did. And after that, that was in September 18. We provide almost 3 months of antibiotics for that lady, and the pain. I mean, the reason to came with us was the pain in her shoulder without a good movement. And with the spacer, she improved the pain. She improved the pain. It was no pain at that time, but the movement was improving with the time at the time. And look, after 2 months, she fine. This is the spacer. And after 4 months, she's still fine without pain. And the improvement was almost a 90 degrees of elevation and 10 and 20% of external rotation. This is almost 8 months after the spacer. And I asked her, say, hey, maybe it's time to change this spacer for a reverse shoulder arthroplasty. And she said, hey, okay, let me see. And after almost a year after the spacer, I said, hey, you really need to change this spacer. Probably I was wrong because she was without pain. And this is the controversial thing. She was without pain, but the elevation was 100% of elevation, 20 degrees of external rotation. For me, was not good movement. For her was, okay, fine. And this is the CT scan, because at that time I was worried about the glenoid bone. And look, this is the glenoid. As you can see here, is less bone in the upper part of the glenoid than in the lower part, but this is still a bone there. And more than a year, she came with me again and said, hey, maybe now it's time to change this spacer. And we repeat the CT scan, and look, this is a really bad glenoid. I mean, this is the inferior part of the glenoid, but in the upper part, I mean, the erosion of the glenoid was in the upper part. Okay, at that time, when she told me, now I really want to change my spacer, almost 18 months after the spacer implantation. What would you do, Dr. Sperling, with this glenoid erosion? Maybe a metal glenoid or what?
So just a couple little things. Again, no right or wrong way. I think one thing we've learned over time is that we like to put spacers to have gent and vanc both, particularly if you have C acnes in there. So we many times a pre-made spacer with low dose gent can take care of it, but we prefer to do gent and vanc both in there. That's one thing. The second thing is, I agree, I would do a reverse. Technically, one little tip with this is you have to identify the true bottom part of the glenoid. So that's the most challenging part. So I start anteriorly and then work my way inferiorly, and you have to fall off the cliff. You have to truly identify the inferior part of the glenoid. One of the problems I've seen is that sometimes there's a false bottom to the bottom part of the glenoid, and people then place the base plate too high. So for me, this is one you can get a CT scan, you can do a preoperative plan on. I would use an augmented base plate in this case, but just some technical things that may be able to help you.
Okay, thank you very much. Thank you very much. George?
So for me, I'm still nervous about this case. She's young. We think, so I would actually, and I would still do it before I'd consider doing a revision. I would do my infection workup again, ESR, C-reactive protein. And this may be very, very, very controversial. I would actually consider doing arthroscopic biopsies again before I went on to do the revision, just to be absolutely certain we've cleared the infection. And then if those all came back negative, I can't tell you how much I agree with John. What'll happen is that spacer makes a nice, good eburnated bone. The top part of the glenoid looks nice, shiny white, and then you see all the blood at the bottom, and you think, oh, that's the bottom. No, you got to work to get to the bottom and get that base plate down. So I would definitely do a full wedge augmented base plate on this, and ideally try to do a press fit humerus. If I couldn't do a press fit, I'd do a cemented. But for me, it would be just making absolutely certain she's not infected because she's so young.
Guido, I would think exactly like George. And having said that, when you put the spacers, I'm sure you send all of the tissues to a lot of cultures, and all of them were absolutely negative, okay?
Yeah, sure. Actually, in the follow-up of this lady, we did blood tests, and all blood tests always was fine after the spacer. You know, after the first time, all the blood tests was fine. And remember, she has 18 months after the spacer. I say, okay, this is enough time to whatever bacteria or something grew up, and she's still fine. I mean, without pain, blood test fine.
Normal.
Yeah, exactly. But
Okay.
I mean, at that time, I mean, I'm glad to everybody say that it's not a good or bad answer, because I did a different thing. I did a reverse shoulder arthroplasty, and with a frozen biopsy at that time of the surgery, with 2 neutrophils in the 1 high power field. I mean, the biopsy was negative at that time, but I really was concerned about the superior part of the glenoid because I didn't feel comfortable, and I took the distal clavicle and I used that bone to reshape the glenoid in order to get a really good stability of the glenoid. That's what we did. In October, she's still fine. In June, I mean, 1 year or more than a year of the surgery, she's still fine. There's no displacement of the clavicle. That one is one of the critics of this technique. The humeral stem was fine. I mean, and she's very, very well and happy. She's still without pain, and the movement changed, but dramatically. Before the reverse, she was no more than 100 degrees of elevation, and after surgery, she improved the movement and no pain.
Beautiful, beautiful. But in spite of the beauty of the case, do you agree with me that there is still a gap in terms of what exactly infection was that in the beginning of the case?
Yeah, that is true. Do you know what we thought that this is a really, really a rare case? And this is a controversy too, because we thought that maybe she has a septic arthritis in her shoulder without treatment, without antibiotic treatment, and just her body resolve the problem, the infection problem, making that fibrosis in the joint. I know this is a controversy idea. Maybe many of you will not agree, but that is my answer for that question, because everything was negative. I mean, no neurological problem, no tuberculosis, no other joints problems. Everything resolved in her shoulder with this treatment. I don't know. I mean, it was.
And my last question, would you consider, just by exclusion, a monoarticular rheumatoid problem, because it exists, a monoarticular rheumatoid problems once you rule out infection?
Yeah, maybe it could be. I'm not sure.
Okay.
I should say that I'm not sure, but maybe it could be, yes.
Okay.
Thank you very much, Guido. Great
Thank
case.
you.
Oh, thanks to you. Thanks to you for all your comments.
Well, we are on time. I think it was a very nice session. We have different options, different complications, how to deal with them. Thank you all for your participation, for your kindness to give us your experience. And we hope that in the future we will be able to join again to discuss these topics. Juan Carlos, I don't know if you want to say.
No, just to thank our speakers, our moderators, and you for taking the time to organize all this. Danny, it was wonderful to be with all of you, and John, George, and Fernando and Carlos, we would love to have you back here. Guido and Diego, thank you very much. Thank you very much to all of you, and I think we should go, Danny. Thank you very much.
Thank you very much.
Thank you all.
Thank you.
Bye. Pablo, bye.
Thank you all. Thank you very much.